The Gigantism and Acromegaly Due to Xq26.3 microduplications and GPR101 mutations. The definition is clinical. The relevant pituitary adenomas have a prevalence of about 1 per thousand in the general population and are an importance of mobility due to the combined impact of hormonal dysfunctions and tumoral mass effects. About 5% of cases occur in an inherited or familial settings. Some of the forms component of multi-site tumor syndromes like multiple endocrine neoplasias, type 1 and Kearney complex, among others.
Acromegaly is the clinical manifestation of excessive growth hormone. So let's talk about how the growth hormone is produced. Normally, the hypothalamus, which is at the base of the brain, secretes the growth hormone releasing hormone. The growth hormone releasing hormone then acts directly on somatotrophs of the anterior pituitary to induce transcription of the growth hormone gene and thereby to stimulate both synthesis and secretion of growth hormone. The main cause of acromegaly is a pituitary adenoma, which is a tumor of somatotroph cells in the anterior pituitary gland. These somatotroph cells continuously make excess growth hormone. More rarely, acromegaly can result from hypothalamic tumors that release too much growth hormone releasing hormone, or even tumors from other parts of the body that start producing the growth hormone ectopically, meaning that it comes from an unexpected location. When the pituitary gland releases the growth hormone into your bloodstream, it triggers your liver to produce a hormone called insulin-like growth factor 1. IGF-1 is what causes your bones and other tissues to grow. Too much growth hormone leads to too much IGF-1, which can cause acromegaly signs, symptoms, and complications. The symptoms of acromegaly, which can take years before they are recognized, include growth of the bones of the hands, feet, and lower jaw, and protrusion of the forehead, soft tissue swelling in hands, feet, face, and tongue, increased size of organs, and excessive sweating. The diagnosis of acromegaly can be made when there are elevated levels of insulin-like growth factor 1 and growth hormone. An MRI can help confirm the presence of the pituitary tumor. Treatment of acromegaly depends on the underlying cause. If there's a pituitary adenoma, then surgery can be done to try to remove the growth. And in cases where that doesn't work, radiation therapy can be used. Medications like somatostatin analogs can also be used to limit the growth hormone production. Alternatively, growth hormone receptor antagonists can be used to stop growth hormone from binding to target tissues.
Do not forget to like the video and subscribe to our YouTube channel.
The pros and cons, the somatic growth, the orchestrated by the complex hormonal crosstalk involving the hypothalamus. The pituitary and peripheral tissues genetic disorders that affect this network can lead to increased secretion of growth hormones. And the result can be gigantism. The non-syndromic gigantism is most frequently caused by pituitary adenomas occurring as familial isolated pituitary adenomas.
Difference between gigantism and acromegaly. Gigantism and acromegaly are two disorders with the same disease mechanism and somewhat similar presentations. Even though they have the same disease mechanism, the two have entirely different outcomes simply due to the age of onset. Gigantism is the result if the disease mechanism starts in childhood. Acromegaly is the result if the disease mechanism starts after puberty. This article will discuss the disease mechanism and the clinical features, symptoms, causes, investigation and diagnosis, and prognosis of acromegaly and gigantism, and also the difference between the two disorders.
The ancient applied in Ecuador is acromegaly is a consequence of chromate growth, the hormone GH. Excess due in the majority of cases to GH secreting pituitary adenoma and occurrent with a population prevalence of 60 millions and the incidence of 3 or 4 per million per years. The males and females appear to be equally affected with an average age of presentation 44 years. Younger patients may have more aggressive tumors and higher GH concentrations.
Growth hormone is pulsatile throughout the day and is not useful for the diagnosis of acromegaly. The best screening test is a serum IGF-1 or insulin-derived growth factor. Excess growth hormone is confirmed with an oral glucose tolerance test because glucose normally suppresses growth hormone levels to less than 1 nanogram per ml. Growth hormone levels greater than 1 nanogram per ml are diagnostic of growth hormone excess. Anterior pituitary MRI should be obtained once growth hormone excess is confirmed biochemically to rule out a pituitary lesion. Acromegaly is the clinical syndrome that occurs when a pituitary tumor secretes excessive amounts of growth hormone in an adult patient. Prior to puberty, patients with growth hormone secreting tumors develop excessive longitudinal growth and gigantism above normal for age. Let's go through some of the external features of acromegaly again. In the head, there may be prominence of the brow and jawline. There may be an enlarged skull. There may be facial edema and coarsening of facial features, excessive spacing between the teeth, usually of the lower jaw, and finally macroglossia, or enlargement of the tongue. The skin can demonstrate thickening and skin tags, and the hands and feet may be disproportionately large. In the joints, arthritis may be a manifestation, and other internal features include diabetes mellitus, hypertension, colon polyps, and excessive perspiration or hyperhidrosis. Obstructive sleep apnea is usually caused by excessive growth of tissue in the upper airway and in and around the mouth, along with macroglossia, which leads to obstructive symptoms when sleeping. Left ventricular hypertrophy can occur in the heart, and these patients may present with cardiomyopathies. And then finally, there are increased rates of cancers, particularly of the colon, esophagus, and stomach, as well as thyroid and even melanomas. A clinical pearl here is in clinical practice, because of the increased number of colonic polyps, patients are predisposed to colon cancers and will often present as a first feature with blood in the stool. The treatment of acromegaly requires transsphenoidal tumor resection, and surgery is the only treatment that is potentially curative. Remission is achieved when IGF-1 levels are within the normal range for age, and the response of growth hormone to glucose tolerance test returns to normal. Patients not achieving remission require injectable somatostatin analogs to inhibit growth hormone secretion. High-dose dopamine agonist therapy is marginally effective when the tumor co-secretes prolactin. Pevisigmont, a growth hormone receptor blocker, is then used to lower IGF-1 levels, but it works in the peripheral tissues as an antagonist to growth hormone and does not decrease growth hormone production by the tumor.
The conclusions, we describe a pediatric disorder which we have termed X-linked acromegaly that is caused by an Xq26 that 3 genomics duplications and is characterized by early onset gigantism resulting from an excess of growth hormone duplication of GPR101, probably cases XLAG. We also found a recurrent mutation in a GPR101 in some adults with acromegaly. Thank you.